When you think about modern medicine, we usually we picture this incredibly satisfying, almost like engineering level precision. Like you break your arm, right? The X-ray shows a clean, jagged line, and the doctor just points at it and says, "There's the problem. We put a cast here, and it's fixed."
It's very comforting, isn't it? I mean, we naturally gravitate toward things that are structural, visible, and, easily categorized into either broken or fixed.
Right.
It gives us this sense of control over our biology.
Exactly. But then you zoom into something like the biology of human pleasure, specifically the mecantor of an orgasm. And suddenly that precise mechanical worldview just sort of, well, it shatters.
Yeah, it really does.
You step out of the engineering department and into a landscape that is incredibly complex, highly individualized, and honestly full of diagnostic muddy waters. I mean, there is no simple X-ray for desire.
Which is exactly why the medical field has struggled with it for so long. When you can't just point to a broken bone on a screen, the solutions become, well, far less obvious.
And that brings us to our mission for this custom deep dive. We are taking a highly specific, deeply personal question sent in by you, the listener, and we are, hunting down the real evidence-based answers.
Right.
Your question for us today is, can the O-shot help if you have never had an orgasm?
It's a fantastic, very brave question. And to answer it, we are looking at a really fascinating stack of sources that you provided us.
Right. We've got clinical guidelines on female sexual dysfunction, or FSD, and inhibited sexual desire.
The foundational texts.
Exactly. Plus, we're looking at systematic reviews from the OSU Center for Health Sciences, evaluating platelet-rich plasma trials. We've got actual clinical guides explaining the O-shot from the UK. And we even have a macro-level look at how sexual health research, like erectile dysfunction, actually gets funded on a global scale.
It's a really necessary mix, honestly. I mean, we need the microscopic biological data to understand what the treatment actually does. Right. But we also need those macroscopic realities of how medicine is funded and marketed, to understand why it's being sold to you in the first place.
Because on paper, regenerative medicine sounds like pure sci-fi magic. But as we'll see, the biology of human pleasure is so much more complicated than just like a simple injection. Okay, let's unpack this. What exactly is the O-shot?
Well,
Because I hear this term thrown around by influencers and private clinics all the time, but what is actually happening?
first, it really helps to know that O-shot or orgasm shot is actually just a consumer trademark term.
Oh, really?
Yeah. In the clinical world, what we are really talking about is intimate platelet-rich plasma treatment. So PRP.
Wait, is that the same PRP I hear about athletes getting for torn knee ligaments, or what dermatologists use for skin rejuvenation?
It is exactly the same principle, yeah. So the procedure basically starts with drawing a small amount of your own blood from your arm, just like a standard blood test. They take that blood and they put it into a centrifuge. And the centrifuge spins it at extremely high speeds to separate the red blood cells from the plasma, which effectively concentrates the platelets.
Right, the spinning separates it all out.
Exactly. And once they have that concentrated plasma, it is injected directly into the clitoris and the upper vaginal wall.
Wow, that sounds incredibly intense. But, what is the actual biological goal here? Why do we want a high concentration of platelets down there?
Because platelets are essentially your body's first responders to injury. They are packed with these specific proteins called growth factors.
Okay.
You might see them listed in the literature under heavy acronyms like VEGF or PDGF, but all you really need to understand is that these are your body's molecular signaling proteins. They basically tell the surrounding tissue to start regenerating.
Got it.
When injected, the theory is that these growth factors stimulate angiogenesis.
Angiogenesis, meaning, the creation of new blood vessels.
Spot on. Yeah, they lay down new microscopic highways for blood flow. They also support nerve regeneration, and they enhance the production of collagen and elastin.
Which keeps the tissue plump and flexible.
Exactly.
Let me see if I can visualize this. So it's not like taking a drug that alters your brain chemistry. It's more like, imagine you have a garden that's kind of wilting and struggling.
I like where this is going.
You wouldn't just throw regular water at it. This is like taking your body's own elite microscopic repair crew, equipping them with highly concentrated cellular fertilizer, and dropping them directly into the soil to grow new roots and wake up the whole ecosystem.
That is a brilliant way to picture it. You're trying to fundamentally revitalize the local environment. And what's fascinating here is that because it uses your own blood, meaning it's an autologous treatment, The risk of your body rejecting it or having an allergic reaction is practically zero.
Oh, because it's just you.
Exactly. It's your own biology, just relocated and highly concentrated.
That does sound amazing, but I'm guessing it's not like a magic switch. You don't walk out of the clinic and immediately have a totally different physical response.
Not at all. Tissue regeneration takes significant time. Clinics generally advise that it takes anywhere from 6 to 12 weeks to see the actual physiological changes.
Wow, up to 3 months.
Yeah, you have to wait for those new blood vessels to actually physically grow. And here is a crucial, surprising detail from the clinical protocols that honestly often gets buried in the fine print.
What's that?
Patients are strictly told they must avoid NSAIDs, so, drugs like ibuprofen or aspirin, for 7 days before and 7 days after the procedure.
Hold on, why ibuprofen? If I'm getting an injection in a highly sensitive area, my first instinct is absolutely going to be taking a common painkiller like Advil.
It's a very natural instinct, but those specific anti-inflammatory drugs chemically deactivate the platelets.
Wait, really?
Yeah. Their entire mechanism of action is to reduce inflammation, right? But the initial inflammatory response is exactly what signals the platelets to start working.
Oh, I see.
If you take an ibuprofen to manage the mild pain of the injection, you are literally stopping the platelets from releasing those precious growth factors. You're turning off the very repair crew you just paid, hundreds or thousands of dollars to inject.
Wow. Okay, so if popping a standard painkiller can chemically sabotage the entire procedure, the margins for error here are incredibly tiny.
Very tiny.
Which really makes me wonder, does the actual clinical data show this is worth the risk and the cost? Like, does this physically give you better orgasms?
This is where we have to step out of the marketing brochures and look directly at the data. And we need a heavy dose of reality here.
Okay, hit me.
Researchers at the OSU Center for Health Sciences, led by a team under Hunt, looked at the clinical trial database, specifically for PRP and female sexual dysfunction.
So they went hunting for the proof.
Exactly. Imagine searching the global medical database for definitive proof that this works. They started with 110 promising leads, search results that seemed related. But as they looked closer, almost all of them evaporated because they just weren't relevant to this specific use case. They were left with only 18 relevant studies.
Just 18.
And of those 18, only 33.3% were actually completed trials.
So we are looking at a tiny, tiny fraction of completed data to base this all on.
Yes. And the results of that data are, at best, a very mixed bag. I mean, for instance, a 2023 study by Pergidis showed statistically significant improvements in orgasm and lubrication after 2 PRP sessions.
Okay, that sounds promising.
It does. But then, if you look at a 2024 randomized controlled trial by Wage, they found absolutely no statistically significant improvement in sexual function scores when compared to a placebo.
Wait, 0 improvement over placebo, so a basic saline injection did just as well as the super concentrated elite repair crew.
In that specific trial, yes. And we have to remember that the placebo effect is incredibly powerful in sexual health.
Right.
Sometimes, just the act of seeking treatment, paying for it, and believing you are being fixed lowers a person's performance anxiety enough that their body can suddenly function normally.
Because the anxiety was the roadblock, not the blood vessel.
Precisely. And this leads to a crucial piece of context. The O shot is widely considered off-label and experimental for sexual enhancement.
Really?
Yeah. It is not endorsed by major regulatory bodies like the NHS in the UK, the FDA in the US, or NICE. Where it does have much stronger clinical backing is for treating highly functional physical issues.
Like what kind of issues?
Things like severe scar tissue from childbirth, a painful skin condition called lichen sclerosus, or genitourinary syndrome of menopause.
Right, where the drop in estrogen has caused the vaginal tissue to severely thin out and become fragile.
Exactly. For those structural issues, it shows real promise.
Okay, I have to stop and admit I'm genuinely confused then. If the evidence for sexual enhancement is this fragmented, and the sample sizes are small, and major health bodies don't endorse it for this purpose, why am I seeing ads from private clinics heavily marketing this to women specifically as, like, an orgasm cure?
Well, if we connect this to the bigger picture, you uncover a massive systemic issue in how medical research is funded and, frankly, who gets left behind.
So we need to follow the money.
We do. Let's look at the data provided in your sources regarding erectile dysfunction, or ED.
Okay.
Today, ED affects millions of men and is widely recognized by the medical community as a vital early warning marker for cardiovascular disease.
Right. It's a huge deal in men's health.
Yet, It receives a remarkably modest amount of public research funding compared to massive public health issues like cancer or diabetes.
But there are pills everywhere for ED. I mean, the market is completely flooded with them.
Yes, but that research was overwhelmingly funded by private pharmaceutical companies historically. Think back to the blockbuster discovery of PDE5 inhibitors like sildenafil.
What we all know is Viagra.
Exactly. It was originally studied for the heart, but they discovered a very clear mechanical side effect. They saw a structural fix that could be easily patented and mass-marketed.
Right. A literal pill that fixes the plumbing, it increases blood flow, and the problem is solved.
Exactly. But female sexual dysfunction, or FSD, is vastly more complex. It involves hormones, vascular health, neurology, and psychology all tangled together.
It's not just plumbing.
No, it doesn't have an easy one-pill biological equivalent.
Yeah.
And because male sexual dysfunction relied so heavily on private pharma money rather than massive public health grants, FSD was left even further behind.
Because there isn't a simple mechanism to patent, pharmaceutical companies couldn't just bottle an instant fix, so the funding dried up.
Precisely. And without massive, publicly funded, long-term randomized clinical trials to establish a baseline of care, a massive void was created.
And what fills a void in medicine? Private enterprise.
Exactly. Women are left navigating a totally unregulated landscape of private, brand-name procedures. The O-shot, the G-shot, vaginal lasers.
So bringing this back to you, the listener, when you are dealing with something as deeply personal and distressing as never having had an orgasm, you are vulnerable.
Highly vulnerable.
And you are stepping into a medical space where commercial, private products are moving way faster than peer-reviewed science.
Which perfectly brings us to the very core of your question.
Yes. Here's where it gets really interesting. Your specific mission for us was, can this shot help if you have never had an orgasm?
Right.
We've talked about what the shot mechanically does and the state of the research. Let's talk about the diagnosis itself.
In medical psychology, female orgasmic disorder, or FOD, is broken down into two main clinical categories. It can be acquired, which is a secondary condition, or it can be lifelong, which is a primary condition.
Let's clearly define those. What makes it acquired?
Acquired means you used to experience regular sexual desire and orgasms, but something changed. A disruption occurred. That could be physical trauma from a difficult childbirth, like an episiotomy scar. Yeah. It could be severe nerve damage from a surgery. Or it could be significant tissue thinning and estrogen loss during menopause.
Okay, so that's acquired. What about primary?
Primary or lifelong means the person has never experienced an orgasm under any circumstances, not with a partner and not alone.
Okay, let me see if I'm tracking this logically. If we take what we learned about the O-shot, that it's an elite repair crew designed to lay down new blood vessels and fix damaged nerves, and we apply it to those definitions, if it's acquired, meaning something broke or aged, the repair crew makes sense.
Correct.
But if it's lifelong, the tissue isn't broken. It hasn't aged out of working. To use our analogy, the garden soil was never depleted. The plants just never bloomed.
You see the fundamental mismatch immediately. The O-shot is designed to treat secondary physical changes. It regenerates aged or traumatized tissue.
Right.
But if you have never had an orgasm, your tissue is likely perfectly healthy.
So injecting regenerative growth factors into healthy, undamaged tissue is highly unlikely to be the magic bullet. You're trying to fix a structural problem that doesn't exist.
Exactly. For primary anorgasmia, the issue is incredibly rarely a lack of blood vessels or a structural defect in the clitoris.
Then what is the actual issue? If the hardware is fine, what's going on?
It is vastly more often related to the mind-body connection, how the nervous system interprets pleasure signals, or, quite simply, never having discovered the exact right type of physical stimulation for your unique anatomy.
So if the O-shot isn't the primary answer for someone who has never climaxed, what does the actual medical evidence recommend? If you're standing at square one, where does a person actually start?
Well, the very first step is normalizing the baseline, because our culture gives us a wildly distorted view of what female pleasure is supposed to look like.
That's true.
According to the data in our sources, only about 25% of women always, or nearly always, experience an orgasm during intercourse alone.
Just 25%? 1 in 4?
Right. The idea that penetrative sex naturally, automatically leads to climax for women is a persistent, damaging myth.
Yeah.
The vast majority of women require direct, dedicated stimulation of the clitoral complex. So the very first medical intervention isn't a needle. It's education and exploring different types of stimulation.
And the sources point to a highly effective evidence-based treatment for this, right? It's called directed masturbation, or DM.
Yes, directed masturbation training is universally considered the gold standard for treating primary anorgasmia.
How does it work?
It involves a graded, step-by-step exploration of your own body. It often uses mirrors for anatomical education, learning exactly where sensitive structures are, and eventually incorporating vibrators to map out what actually feels good.
And crucially, it's done alone, without the pressure or presence of a partner.
Exactly.
And the success rates for this are kind of staggering, especially when you compare them to the mixed bag of the O-shot data.
They are phenomenal. Clinical studies consistently show a 60 to 90% success rate in helping women climax for the very first time using DM training.
60 to 90%. And that's without drawing a single drop of blood or spending thousands of dollars at a private clinic.
Right.
But reading through the psychology sources you brought in, it seems like it's not just about finding the right physical spot. A huge part of this happens in the brain. The texts talk extensively about this concept called spectatoring.
Spectatoring is a massive, often invisible barrier. It's a psychological phenomenon where you are in an intimate situation, but instead of actually feeling the physical sensations happening to you, your brain is hovering outside your body.
Like watching yourself.
Yes.
Yes.
You are evaluating your own performance from a third-person perspective. Like, am I taking too long? Does my body look okay in this light? Is my partner getting bored?
You're grading your own exam while you're trying to take it. You're completely disconnected from the physical feeling.
Exactly. And it's not just a distraction. That performance anxiety, along with things like chronic stress, depression, or unresolved relationship conflict, literally shuts down the neurological arousal pathways.
Physically shuts them down.
Yeah. Your body perceives that anxiety and goes into a sympathetic nervous system state, which is your fight or flight response. When your body thinks it's under threat, your cortisol spikes and orgasm becomes physiologically impossible. The brain literally blocks the signals.
This raises an important question. If your nervous system has essentially learned to block those pleasure signals as a defense mechanism, how do you retrain it?
This is where targeted psychological interventions like sensate focus come in. It's a formalized series of exercises, often done with a partner, where the strict, non-negotiable rule is that orgasm is entirely off the table. You are not allowed to try for it.
You just completely remove the goal.
Yes. By removing the pressure of the goal, the brain no longer has anything to evaluate, so it stops spectatoring. You practice pure mindfulness, shifting your attention solely to the physical sensation of touch.
Like just being present.
Right. The temperature of the room, the pressure of a hand, the texture of skin. The goal is to rebuild the proprioceptive feedback loop.
Let's define that. What is a proprioceptive feedback loop?
Proprioception is basically your brain's internal 3D map of your body. It's how your nervous system knows where your body is in space and how it perceives being touched.
Okay.
When anxiety severs that connection, you go numb. Sensate focus rebuilds that map in a safe, low-stakes environment.
You're slowly teaching the nervous system that it is safe to feel pleasure again without any expectations.
Precisely. You are actively rewiring the neural pathways. And that is a deep psychological and neurological process that an injection of concentrated platelets simply cannot do.
So let's look at what we've discovered on this deep dive. The O-shot is a genuinely fascinating emerging tool in regenerative medicine.
It really is.
Using your body's own growth factors to repair tissue and stimulate new blood vessel networks is incredible science. And the data suggests it has real potential for women dealing with secondary issues like postmenopausal thinning or localized trauma.
But for the specific question you asked us, can it help if you have never had an orgasm? The O-shot is almost certainly treating the wrong target.
Yeah.
The journey doesn't start with an experimental structural repair. It starts with exploring the mind-body connection, ensuring you are receiving the proper clitoral stimulation and utilizing proven, highly effective behavioral techniques like directed masturbation.
So what does this all mean? It means you should never feel pressure to buy an expensive experimental procedure to fix a body that, in all likelihood, isn't broken to begin with. You just haven't been given the right map yet.
And I want to leave you with a final thought to mull over, looking toward the future. Right now, regenerative medicine is focused on blood vessels and tissue physical structures. But as medical science advances, we're getting closer to therapies that can directly target and alter the nervous system's perception of pleasure.
Oh, wow.
For decades, modern medicine treated male sexual dysfunction as a simple plumbing issue to be fixed with a pill, while treating female sexuality as an overly complex psychological mystery.
Right.
But when we look at procedures like the O-shot, Are we now making the opposite mistake? Trying to force a purely structural plumbing fix onto the beautifully complex, holistic system of female pleasure?
That's a great point.
And if, in 20 years, we have the technology to bypass the complex, holistic mind-body connection entirely and simply download or engineer a climax through neural interfaces, what happens to human intimacy? If pleasure becomes just another structural, programmable output, do we lose the vulnerability and connection that makes it meaningful in the first place?
That is a wild, slightly terrifying, and completely fascinating thought to end on. Thank you so much for trusting us with this question and for letting us take this custom deep dive with you. Keep exploring the science, keep questioning the marketing, and most importantly, keep listening to your own body. We'll catch you on the next one.